Good morning to some, good afternoon to others. I'm Marita Mailman, Director of the Region 2 Public Health Training Center. Our center is one of 10 regional public health training centers recently funded by the Health Resources and Services Administration. We are a collaboration of Columbia University, Mailman School of Public Health, Rutgers School of Public Health, the University of Puerto Rico Graduate School of Public Health, the University of the Virgin Islands Community Engagement and Lifelong Learning Center, and the New York State Association of County Health Officials. Our mission is to enhance the public health workforce's ability to effectively deliver the essential public health services to the populations in New York, New Jersey, Puerto Rico, and the U.S. Virgin Islands. Our designated national public health content area is health disparities, health equity, and social determinants of health. Please consider following us on Twitter and on Facebook. Before I introduce today's speaker, I just want to let you know that following the webinar, Dr. Hatzenbuehler's slides and recommended reading will be emailed to registrants. When the edited video has been updated to YouTube, registrants will receive another email with this link. It now gives me great pleasure to introduce Dr. Mark Hatzenbuehler. Dr. Hatzenbuehler is an assistant professor of Sociomedical Sciences and co-director of the Center for Social Inequalities and Health at Columbia University Mailman School of Public Health. The title of Dr. Hatzenbuehler's presentation is Structural Stigma and the Health of Lesbian, Gay, and Bisexual Populations. Mark?
Thanks for the introduction, and I'm looking forward to presenting some of the work that my colleagues and I have been doing on this topic of structural stigma and the health of lesbian, gay, and bisexual or LGBT populations. In terms of the learning objectives for today, I have 3 learning objectives. The first is to define structural stigma, define this concept and what we mean by it, and also talk about some of the ways in which structural stigma differs from stigma at the individual and interpersonal levels of analysis. I'm then going to describe a variety of different methodological approaches that my colleagues and I have used to study the impact of structural stigma on LGBT health. And then finally, we'll describe some of the research evidence linking these structural forms of stigma to adverse health outcomes among LGBT populations. So in terms of the outline, I'll briefly describe some of the descriptive epidemiology of sexual orientation health disparities. Then I'll define stigma as a particular determinant of these disparities, and we'll talk about stigma across different levels of analysis, ranging from individual to structural. Then I'm going to be presenting evidence from 4 different studies linking structural stigma to the health of LGBT populations. These methodological approaches include observational studies, including cross-sectional and longitudinal, as well as quasi-experimental studies, and then finally a laboratory-based paradigm. And we'll end with some conclusions about some of the implications of this work for public policies and for practice. So for those of you who are new to the field of sexual orientation health, I'm just going to very briefly review some of the epidemiologic data on sexual orientation disparities in mental health. So these data come from a nationally representative survey of U.S. adults age 18 and over that my colleagues and I published in the American Journal of Public Health. And in this study, we showed that about 55% of lesbian, gay, and bisexual adults met criteria for any Axis I psychiatric disorder in the past 12 months, compared to only 35% of heterosexuals. And that pattern of health disparities persisted across multiple different subclasses of mental disorders, including any mood disorder, any anxiety disorder, and any substance use disorder, as well as for psychiatric comorbidity, which we defined as the presence of 2 or more co-occurring psychiatric disorders. And this is an index of illness severity. All of these differences were statistically reliable, indicating that LGBT adults are at significantly higher risk for a variety of psychiatric disorders compared to their heterosexual peers. And these findings have been replicated now across a variety of different population-based surveys here in the US. There's comparatively less research on physical health disparities by sexual orientation status outside of the area of HIV, but there's accumulating evidence for sexual orientation disparities in a variety of different physical health outcomes. These are data here from a population-based survey of adults in Massachusetts. You can see in the red bars here that lesbian, gay, and bisexual adults are at significantly higher risk for a variety of different chronic health conditions such as diabetes, heart disease, asthma, and high cardiovascular disease risk compared to heterosexuals. So this first sort of generation of research has consistently established higher rates of mental and physical health outcomes among LGBT populations compared to their heterosexual peers. And so the second generation of research has begun to try and understand what are the causes of these health disparities. And stigma has emerged as one of the most frequently hypothesized risk factors to explain sexual orientation disparities in health. And as you can see on this slide, stigma has been conceptualized in the literature as a multi-level construct ranging from individual and interpersonal forms all the way up to structural forms of stigma. So stigma at the individual level refers to the psychological processes through which stigmatized individuals both perceive and react to stigma. So these can include processes like being sensitive to rejection based on your sexual orientation, or to internalizing the negative societal views of your group, that is, of sexual minorities, incorporating those negative attitudes into your self-concept. This is a concept known as self-stigma or internalized homophobia. In contrast, at the interpersonal level, interpersonal forms of stigma refer to interactional processes that occur between the stigmatized and the non-stigmatized. So these can refer to more objective events, like bias-based hate crimes, but they can also refer to more subtle interactional processes like microaggressions. So the vast majority of research on stigma more broadly, as well as in stigma with LGBT populations, has really focused at these two levels, that is, at the individual and interpersonal level. But more recently, researchers have begun to turn their attention to these broader, what we call structural forms of stigma. And my colleague, Bruce Link, whom you heard from last month, we've defined these structural forms of stigma as societal level conditions, cultural norms, and institutional policies and practices that constrain the opportunities and resources and well-being of the stigmatized. One example of these structural forms of stigma are social policies that differentially target particular stigmatized groups for social exclusion. So as just one example, here in this slide you can see that there is variation across the US state with respect to whether or not sexual orientation is included as a protected class status in employment non-discrimination laws. And currently, gays and lesbians can still be legally fired in numerous states because of their sexual orientation, because again, they're not protected under current employment non-discrimination acts. So my colleagues and I have used a variety of different measures of structural stigma and shown that these structural forms of stigma contribute to adverse health outcomes among LGBT populations. So in the remainder of my talk, I'm going to describe a series of studies that we've conducted providing some evidence for the adverse health consequences of exposure to structural stigma. And I'll talk through 4 different methodological approaches that we've used. So the first approach are cross-sectional observational designs. As I mentioned, there's a variety of state-level policies that differentially target gays and lesbians for social exclusion in the US. So we have enough variation at the state level. This is one aerial unit where we can examine the impact of these structural forms of stigma on health. So in this first study that I'll be presenting, that my colleagues and I published in the American Journal of Public Health, looked at the associations between these state-level policies and psychiatric disorders among LGBT populations. In this study, we examined 2 state-level policies. We looked at hate crime laws as well as employment non-discrimination laws that specifically included sexual orientation as a protected class status. And then we created a dichotomous variable. So we compared states with no protective policies versus states with at least one of these two protective policies. And hopefully you'll forgive my perpetuating the red state, blue state distinction, but I've shown in red here states that did not have either of these two protective policies, and the blue states are the states that had at least one of these two protective policies. So then, in order to examine associations between state-level policies and mental health, we use data from the NESARC. This is the National Epidemiologic Survey on Alcohol and Related Conditions. As you can see, it's a large-scale survey, nearly 35,000 participants in the second wave. It's nationally representative of U.S. non-institutionalized adults. And researchers use semi-structured face-to-face interviews which generated DSM-4 psychiatric diagnoses. So we had mental health on everyone interviewed in the sample, and sexual orientation was also assessed in this data set. So we have a measure of sexual orientation identity, we had measures of mental health, and we also knew that the states in which the respondents lived. So we had all the different elements to see the extent to which mental health differs as a function of living in states with different policy regimes. So in this next slide shows the results for this study. On the y-axis are the adjusted odds ratios indicating the likelihood that LGB respondents met criteria for a psychiatric disorder relative to heterosexuals. And on the x-axis are the disorders where we find a significant interaction between state-level policies and sexual orientation. So I'm going to walk you through these results, first starting with dysthymia. So this dysthymia, for those of you who aren't in the mental health field, it's a mental health diagnosis. It's a mood disorder. By definition, it's more chronic, but less severe than a major depressive episode. So LGB adults living in states with protective policies were actually no more likely to meet criteria for this mood disorder than were heterosexuals living in these same states. That is, the mental health disparity in dysthymia was eliminated in states with protective policies. In contrast, LGB adults living in states with no protective policies were nearly 2.5 times more likely to meet criteria for this mood disorder than were heterosexuals in those states. We find similar results for generalized anxiety disorder. This is an anxiety disorder by chronic tension and worry. Here we find that LGB adults living in states with protective policies are only about a little more than 1.5 times more likely to meet criteria for this anxiety disorder than are heterosexuals in those groups. But in contrast, LGB adults living in states with no protective policies are nearly 3.5 times more likely to meet criteria for this anxiety disorder than are heterosexuals living in those same states. So I won't belabor the point here, but we find similar results for other mental health outcomes that we examined as well. So the take-home message here is that differences in disorder prevalence individuals and heterosexuals is significantly weaker in states that extend these protections, policy protections to gays and lesbians. Or stated in another way, LGB individuals have significantly higher rates of psychiatric morbidity if they live in states with these structural forms of stigma. Another approach that we've used within this first approach of cross-sectional observational designs is a country-level approach. And that is, countries are another areal unit of analysis where there's substantial variability across countries with respect to their laws and policies around sexual orientation, which gives us enough statistical power to detect an effect should one exist. So in this study, we used a similar approach, only here we're using countries as the unit of analysis. And you can see from this map here that policy regimes differ substantially across European countries. So this was an index that was created ranging from 0 to 100, 100 being having the most LGBT protective rights, 0 being the least. You can see that there's a wide range here from 6% in the Russian Federation all the way to 82% in the United Kingdom. So we were able to link this ecologic data on policies at the country level to individual health outcomes among men who have sex with men who are living in these different countries. And these health outcomes come from the EMIS study. This is the European Men Who Have Sex with Men Internet Survey. They came from 38 different European countries with a very large sample size of over 174,000 participants. And what we did is examined the relationship between structural stigma in the form of these policies at the country level, and examined associations between that and individual level HIV risk outcomes that are listed over here in the table. And you can see here that for each of these HIV outcomes, we see substantially higher HIV risk in countries with greater forms of structural stigma. So these outcomes range from things like inadequate HIV prevention reach to testing for HIV and sexually transmitted infections, as well as for health behaviors, for instance, around things like condom use. And these analyses adjust for a variety of different potential confounders at both the individual and the country level status. So again, another example of how in a cross-sectional study of how these structural forms of stigma are associated with adverse health outcomes among LGBT populations. In the second methodological approach that I'll be talking about today, we have moved from these cross-sectional designs to using longitudinal or prospective designs in order to improve our causal inferences. Because, of course, cross-sectional studies can give us important information about associations of interest, but longitudinal designs provide clearer causal inferences about these relationships between structural stigma and health. So in the study that I'll be presenting today, which we published in the Journal of Social Science and Medicine, which was part of a special issue on structural stigma and health that I recommend you looking into, we examined associations between structural stigma and all-cause mortality among sexual minority populations. As you can imagine, this research question is very difficult to address because you need measures of sexual orientation, which is already rare in population-based studies. You also need measures of structural stigma, and you need enough variation across those measures to have enough statistical power. And finally, because mortality was our outcome of interest, we need data over longer periods of time. And it wasn't until very recently where we had a data structure that permitted the examination of this research question. In particular, my colleague, Peter Munig, here at Columbia, has created a really innovative data set that linked the General Social Survey to the National Death Index. So some of you might be familiar with the General Social Survey. This is one of the primary sources of social indicator data for the social sciences. And they're repeated cross-sectional surveys that generate representative samples of the US non-institutionalized population. And then what Peter and his colleagues did is they linked participants from 18 different waves of the General Social Survey to mortality data via the National Death Index. So we have mortality information on a large subsection of the population from the General Social Survey who's been assessed. Let me explain now just a little bit about the data structure for this study and how we were able to examine this relationship between community-level prejudicial attitudes and mortality risk among sexual minorities. So what we did is we took the 4 items in the General Social Survey that asked people's attitudes towards homosexuality, and we aggregated those individual responses up to the community level. So the innovation here is that we're not asking gays and lesbians themselves about their appraisals or perceptions of stigma in their communities, but instead we're actually asking the individuals who live in those communities what their own attitudes are towards gays and lesbians. And then we aggregate those individual responses up to the community level, such that each community that was examined in the General Social Survey has an average stigma or an average prejudice score. So I'm showing here on this slide just 2 hypothetical, these are not real, but hypothetical communities in the General Social Survey that you can see differ a lot as a function of the level of prejudice in those communities. So for instance, Shelby County, which is a community in western Tennessee, you can see that the mean score of prejudicial attitudes, which ranged from 0 to 4, was 3.2, so very high levels of prejudice, compared to San Francisco, a very different community, which has much lower levels of prejudicial attitudes. And then again from the General Social Survey, we know the sexual orientation of the participants in the GSS. This is measured by a behavioral measure of sexual orientation. And finally, because the GSS was linked to the National Death Index, we have mortality information on those sexual minorities who lived in those different communities. So this shows you the results for this study. These were results were conducted using survival analyses, given that our outcome was time to death. You can see here that even after controlling for a variety of different socio-demographic characteristics, as well as characteristics at the community level, we find that living in communities with higher levels of structural stigma, as measured by the level of prejudice in those communities, is associated with an increased risk of mortality among sexual minorities who live in those communities. One index that some researchers use is life expectancy differences, and you can translate these hazard ratios into life expectancy differences. So this hazard ratio of 3.03 for structural stigma translates into a life expectancy difference of, on average, 12 years, indicating that sexual minorities living in the highest structural stigma communities have a life expectancy difference of 12 years compared to those living in in communities with lower levels of structural stigma. Now, there's an important caveat here that you can see there's a very large range around this point estimate from between 4 and 20 years, and that's because of the relatively few number of deaths of sexual minorities in this sample. Nonetheless, this life expectancy difference is fairly comparable to life expectancy differences that we see based on socioeconomic status, one of the most robust risk factors of health, suggesting that stigma might be or should be considered alongside some of the other major social determinants of population health. This figure here is showing the same results, only in the form of a figure. You can see here on the x-axis is the percent alive, and on the y-axis is percent alive, and on the x-axis is time in years. And you can see that by the end of this study, 92% of the sexual minorities who lived in the lowest structural stigma communities were still alive at the end of the study. But in contrast, only about 78% of sexual minorities who lived in the highest structural stigma communities were still alive at the end of the study. Just one more note about some additional results. One of the other benefits or unique aspects of these data is that we also have the leading cause of death among those who died in the National Death Index sample. These analyses of specific cause of death are from use the ICD-9 diagnostic code. So we were able to look at least descriptively at what specific causes of death were elevated among the high structural stigma communities. And interestingly, we find that these results are not due to HIV-related causes of death, but instead we found 3 causes of death that were much higher in the high structural stigma communities. And these include suicide, homicide and violence, and cardiovascular diseases. So this gives us some insight into potential mechanisms that may explain how it is that these structural forms of stigma produce increased mortality, or are associated with increased mortality risk in sexual minority samples. To me, one of the most striking findings is around the finding of a completed suicide, where if we look at average age of death of completed suicide, we see a striking 18-year difference between those who completed suicide in the highest compared to the lowest stigma communities. One final comment from this study is around testing plausible alternative explanations for these results. So at this point, you might be thinking, well, maybe it's just that the healthy sexual minorities are leaving highly prejudicial communities and sorting into or moving to areas that provide more support, that is to areas with lower levels of prejudice and stigma. So what looks like a social causation story is really one of social selection. Well, because what would happen under that condition is that the unhealthy LGB respondents would be left behind in these states with negative policies. Fortunately, the General Social Survey includes a measure of geographic mobility since the age of 16, and we find no associations between movement or geographic mobility and health. So that is, we don't find evidence that healthier respondents are moving to areas with lower prejudice. So our results are robust to these selection effects regarding geographic mobility. So in the third methodological approach that we've used are what we call quasi-experimental or natural experiments. So of course, it's unethical to randomly assign individuals to live in states or communities with high levels of prejudice or with policies that discriminate against that particular population. So we're not able to do traditional randomized experiments, but instead, in certain situations, we're able to use quasi-experimental designs where we take advantage of naturally occurring changes in social policies. And as long as we have baseline data before the change in the policy occurs, we can look at whether health differs after some change in the social policy compared to the health at baseline. And we've been able to use this approach in a couple different studies, and I'm going to present an example of one of these studies today. This is data from a study that we published in the American Journal of Public Health. And here, we took advantage of the naturally occurring change in policies around same-sex marriage in the U.S. So as many of you will remember, in 2004, during the presidential elections, numerous states passed constitutional amendments banning same-sex marriage. And it just so happened that these events, these changes in policies, occurred in between two data collection periods of the NESARC, which is that data set that I mentioned in the first study. So respondents in the NESARC were first interviewed in 2001, and then the same respondents were re-interviewed again 4 years later in 2005, following the passage of the same-sex marriage bans. So this created a natural experiment of sorts that enabled us to examine changes in the prevalence of psychiatric disorders among LGB respondents who had been assessed both before and after the passage of these policies that ban same-sex marriage. So for the sake of time, I'm just going to be presenting the results for mood disorders, although we find similar results for anxiety and substance use disorders as well. On the y-axis here is the prevalence of mood disorders, and on the x-axis is the state of residence. So on the left-hand side here are LGB respondents who lived in one of the states that banned same-sex marriage, and on the right-hand side here are LGB respondents living in one of the states that did not ban same-sex marriage. So at wave one, before the passage of the constitutional amendments banning same-sex marriage, you can see that the prevalence of mood disorders was essentially identical between LGB respondents who lived in one of those states that ultimately banned same-sex marriage compared to those who lived in one of those states that did not ultimately ban same-sex marriage. However, at wave two, following the passage of the same-sex marriage bans, 31% of LGB respondents living in one of those states that had passed same-sex marriage bans met criteria for a mood disorder. But in contrast, only 17% of LGB respondents who lived in one of those states that did not ban same-sex marriage met criteria for a mood disorder in those states. So that was a 37% increase in mood disorders among the LGB respondents living in a state that banned same-sex marriage, but a 24% decrease in mood disorders among those who lived in one of those states that did not ban same-sex marriage. And our adjusted odds ratios indicate that that is a statistically significant increase in mood disorders among the LGB respondents living in one of those states that banned same-sex marriage. But this is not a significant difference among the LGB respondents living in a state that did not ban same-sex marriage. Although you can see here from the confidence intervals that there's a trend towards a protective effect of living in one of these states that did not ban same-sex marriage, given that the adjusted odds ratio is below 1. In the next set of analyses, we examined the same research question, only here we brought in heterosexuals. So we wanted to determine whether these results were specific to the LGB respondents. So in that case, we used the same approach. We examined changes in the prevalence of mood disorders between wave 1 and wave 2. Only here we're comparing heterosexuals and LGB individuals both living in a state that banned same-sex marriage. So if we have evidence for result specificity, we should see an effect of the same-sex marriage bans among the LGB respondents, but not among the heterosexual respondents who live in those same states. And as you'll see, that's exactly what we found. On the left-hand side here are the LGB respondents, and on the right-hand side are the heterosexual respondents. And again, everyone lived in one of those states that did ban same-sex marriage. So at wave 1, we see that about 22% of LGB respondents who lived in one of those states that had banned same-sex marriage met criteria for a mood disorder, compared to only about 10.9% of heterosexuals living in those same states. However, at wave 2, following the passage of the gay marriage ban, 31% of LGB respondents living in one of those states that had banned same-sex marriage met criteria for a mood disorder, compared to only 11.2% of heterosexuals in those same states. So again, that was about a 37% increase among the LGB respondents, but only a 3% increase among the heterosexual respondents. And finally, our adjusted odds ratios indicate that that is a statistically significant increase among the LGB respondents, but not among the heterosexual respondents. So again, we're finding evidence for result specificity here, that these structural forms of stigma appear to impact the LGB respondents, but not the heterosexual respondents. So in the last study that I'll be presenting today uses a different methodological approach. So here we move from using these large-scale population-based data sets, we move into the laboratory so we can begin to test mechanisms that may explain how it is that these structural forms of stigma ultimately contribute to adverse health outcomes. And one of the, of course, benefits of laboratory-based designs is that you can control experimentally what the respondents are exposed to in the laboratory. So you can see how prior exposure to structural stigma may affect a variety of different psychological and physiological responses. So in the study I'll be presenting today, we're interested in whether structural stigma might actually affect the way in which the body responds to stressors, in particular physiological stress response systems. So to do this, we've examined the HPA axis, which of course is important in regulating the body's stress response system. The HPA axis culminates in the production of cortisol, which is a stress hormone. So in this study, we brought 74 LGB young adults into the laboratory. You can see the demographic breakdown of the sample here. And they were told that the purpose of the study was to understand connections between daily experiences, your bodily activity, and health. So there was no indication that the study was about stigma or the other constructs of interest. So they came in and we had them fill out a variety of different measures, including a measure of stigma at the individual level of analysis. We used a measure that we adapted for use with gay respondents. So some sample items include things like most people think less of gay people. So you're responding about the extent to which your group is devalued or discriminated against. But of course, our main interest is stigma not at the individual level, but instead at the structural level. So what we did is we asked the participants the state that they lived in for the longest period of time during adolescence, that is when they were ages 10 and 18. And that enabled us to create a measure of structural stigma in the state where they grew up during this period of adolescence. And we did that by linking it to a previously validated measure of structural stigma at the state level that I've created. And this measure includes a variety of different components of the social environment surrounding gays and lesbians, including the density of same-sex couples who live in the state, the proportion of gay-straight alliances in public high schools in the state. We create a composite index of different state-level policies that affect gays and lesbians, including things like marriage, employment non-discrimination, and anti-bullying or anti-discrimination. And finally, we use a composite measure of attitudes, state-level attitudes across 41 different national opinion polls about people's attitudes towards a variety of different policies that affect gays and lesbians. So we conducted a factor analysis on these items, and a single factor emerged, suggesting that they're all loading onto this single construct of the level of structural stigma in that environment. And so we sum these scores and then create a z-score that ranges from about -4 to +8. So you can see there's substantial variation across these states with the level of structural stigma in them. So here, this is reverse coded. So negative scores mean more negative climates, and more positive scores mean more positive or supportive climates. That is, climates that have lower levels of structural stigma. So our research question is, how does growing up in an environment with high levels of structural stigma ultimately affect physiological stress response in the laboratory setting? And so in order to examine that, we had our participants complete the Trier social stress test. This is one of the most well-validated stress paradigms in the laboratory. Respondents are told that they have 5 minutes to prepare a speech that they're going to have to give in front of two, what they're told are trained evaluators. They're told that they're evaluators that are trained in the evaluation, especially trained in the evaluation of speech. Unbeknownst to them, these are actually Confederates. They're people that we've trained to give very neutral feedback. So they don't smile, they don't nod, they don't engage with the participant at all, they don't give any sort of positive feedback during the speech. And as if to heighten the social evaluative threat even more, the topic of the speech that they had to talk about was a time in which they've been discriminated against or rejected because of their sexual orientation. So they're having to give that speech in front of two people that they've never met before and don't know the people's attitudes towards gays and lesbians. So as you can imagine, it's a very stressful experience. And then following the speech, there's a 5-minute stress math task. And what we do is we collect neuroendocrine samples via, this is collected via saliva, that we then assay for cortisol. And we have 3 different time points before, during, and after the speech and math task. For those of you who are interested, I have some of the methods here about the storage and the assays and also the statistical analysis of this research study. I won't go into these details now, but I'm happy to answer questions about them during the Q&A. So these are showing you the results first of this study. On the y-axis is the cortisol output, and on the x-axis are the 3 different time points. So time 1 is baseline, time 2 is reactivity, that is 20 minutes after the speech task starts, and time 3 is the recovery period, that is taken 20 minutes after the math task ends. So you can see here, and we're comparing those who grew up in the lowest structural stigma environments compared to those in the highest structural stigma environments. And you can see that there is a blunted cortisol response among those who grew up in the highest structural stigma states. And before I try to interpret those findings, I first just want to show the fully adjusted models. So you can see here that we control for a variety of different factors that are known to affect the cortisol response. And even after controlling for them, we see that structural stigma remains a correlate of HPA axis reactivity. But to me, one of the most interesting findings is, if you'll remember, we also had a measure of stigma at the individual level of analysis, which is the focus of most studies. And you can see here that even after controlling for perceived stigma, these structural forms of stigma remain significantly correlated with HPA axis functioning. And in fact, structural stigma is a more robust or stronger predictor or correlate of HPA axis functioning than is this measure of perceived stigma at the individual level. In terms of interpretations of these findings, this pattern of blunted cortisol response has also been observed among numerous samples, and in particular those that are exposed to chronic life stressors, such as childhood maltreatment. It's also been observed among individuals with post-traumatic stress disorder and other severe forms of trauma, and then experimentally in a sample of females who were randomly assigned to be ostracized. Some of the neurobiological explanations for a blunted cortisol response, one hypothesis that's been put forward in the literature is that receptors for cortisol in the pituitary are downregulated following chronic stress exposure, which might explain this blunted cortisol response. So taken together, these findings suggest, at least in a preliminary way, that the stress of growing up in these highly stigmatizing environments may exert biological effects that are similar to other chronic life stressors. So in conclusion, a couple different concluding remarks. And during this time, please feel free to start submitting some of your questions I'd be happy to take and answer during the Q&A session. So as I mentioned, I've provided evidence across numerous different methodological designs and a variety of different measures of both health and structural stigma, that these structural forms of stigma appear to be robust risk indicators for poor health among LGB populations, and that these structural forms of stigma contribute to adverse health outcomes over and above stigma at the other levels of analysis. And this approach, although we've used it mostly with LGB populations, can also be used with other stigmatized groups as well in thinking about other different kinds of indicators of structural stigma that affect other stigmatized groups here in the US. I also want to talk about, very briefly, some of the implications of this research. In particular, some of the implications around public policies. So as Bruce Link mentioned last week in his last session in his lecture on fundamental causes, many individual level interventions are ultimately ineffective because they don't address root causes. And that message is very similar to the message that I've been giving you today, which is that without addressing these broader social environments in which LGBT individuals are embedded, we're unlikely to move the needle fully in terms of reducing these sexual orientation disparities in health. And this work has been used in a couple different court cases and amicus briefs for a variety of different court cases related to status-based discrimination, providing an example of the use of social science research to inform public policies related to discrimination. So I'll end there. I just want to first acknowledge funders for this research and also my many collaborators, great collaborators on these different projects who I've listed here. Again, we're going to now open up for questions. I think we have about 15 or so minutes, and just to please type your questions into the chat box. So one question asks if any of the findings include other specific minorities as well. So as I mentioned, this approach, in my work, we focused on LGBT populations, but this general approach that we've used of finding indicators of structural stigma and linking them to health outcomes is certainly appropriate for researchers who are interested in other stigmatized groups. And in fact, we've been doing some of this work on our own. In one published study in the Social Science and Medicine special issue that I mentioned on structural stigma, we created an indicator of structural racism at the state level. We used a variety of different indicators of structural racism, including, for instance, policies around voting registration and also around incarceration, differences in incarceration rates and racial disparities in incarceration rates at the state level. And we found that African Americans living in states with greater forms of structural racism were more likely to have reported, self-reported a myocardial infarction compared to blacks living in states with lower levels of structural racism. We also have some data we're working on now where we're looking at the relationship between immigration laws and policies and linking that to health outcomes among Latino populations as well. So let me also clarify that, meaning, of course, LGBT populations, there's an issue around intersectionality. That is that LGBT individuals may also share other stigmatized identities. That is, they could come from low SES groups, they may be racial or ethnic minorities, and does having multiple stigmatized identities, does that impact your health? We have, unfortunately, in many of these large-scale population-based studies that aren't designed around LGBT health, there are very small sample sizes of LGBT individuals. And so it's often difficult to have enough statistical power to detect interactions between, say, race, ethnicity, and sexual orientation. We've looked at this descriptively, and in general, we tend to find that the impact of these structural forms of stigma on health are similar across individuals, so across African Americans and whites, and across Latinos or Hispanics and non-Hispanics in our samples. So we're not finding evidence that these other potential stigmatized identities that the impact of structural stigma differs at all across these other stigmatized identities. There was a question around the implications of these findings for transgender populations. I just want to have a quick, or mention quickly about this. Unfortunately, as I mentioned, I use large-scale population-based data sets here in the US that have actually only recently begun to even include measures of sexual orientation. And currently, although this is going to hopefully change soon, there's actually no population-based data sets that include measures of gender identity. So we haven't been able to answer this question of the impact of structural forms of stigma on transgender health. Although we're currently working on this question where we're using convenient samples of transgender individuals, and so we're starting to look into this issue. One of the other issues or challenges of studying these structural forms of stigma is that you need enough variation in structural stigma to be able to have enough statistical power to detect an effect. And until very recently, there was basically very little variation at the state level in policies that specifically included gender minorities and protected gender minorities. So there hasn't been enough variation and therefore enough statistical power to examine this research question. So we've been hampered in terms of our methods, in terms of being able to address these questions. But again, the policy environment is rapidly shifting around transgender individuals, and also, fortunately, more data sets now are starting to measure gender identity. So I think we're right at the cusp of being able to answer a lot of these questions with transgender populations. A couple of questions around health services access, and we've actually been able to control for this in the NESARC. There are questions of where we have health insurance, questions about whether or not individuals have health insurance, and we control for those factors and still find an effect of these structural forms of stigma over and above access to health services. Clearly, access to health services is a very important factor, but we find that that doesn't impact the relationship between structural forms of stigma and health. Of course, you might consider that access to health at a community level might be impacted by structural forms of stigma, and I think that's certainly the case. But our measure of structural stigma, I think, in many ways is capturing some of those access issues. And this is related to another question that came up about controlling for potential confounders. So as I mentioned, in all of our studies, these are all adjusted estimates where we, to the extent possible, adjust for a variety of different sociodemographic characteristics. So these are all controlled for factors like age, race, ethnicity, income, education. And we also, to the extent possible, control for potential confounders at the community or state level. So, of course, we know states differ in a variety of different ways other than structural stigma. For instance, states differ in terms of the level of income inequality in the state that's unrelated, that may be related or unrelated to the structural forms of stigma in that state. So we use statistical procedures where we control for these potential confounders at both the state level and the individual level. And in these studies that I presented, all these results are adjusted for those potential confounders. And again, we still see a relationship between structural stigma and health over and above these other potential confounders. There have been a couple questions around interventions, and so I guess I have two sort of comments about that. The first is that I think there's at least two implications. One is I think policies in and of themselves are targets for interventions, and they are structural interventions. And so I think in that we need to. And this is why I included the last point in the slides about the use of social science data to inform public policies and to actually have collaborations with public policymakers and legal scholars who are arguing court cases related to status-based discrimination. That public health really has a seat at that table and should be more represented in some of these discussions, particularly when we have data linking these laws and policies and structural forms of discrimination to poor health outcomes. And so I think that we should very much view these policies as structural interventions in and of themselves. So to work collaboratively with different stakeholders who are working to address those laws and policies. The other point I'll mention too is that, and this was I think alluded to in Bruce Link's talk last time, is that oftentimes in public health, we only are working at the individual or interpersonal level, and that's clearly very important here. I don't want to undermine the importance of that work. But if we're not changing the surrounding social environments, what can happen is the individual level risk factors can reset to harmful levels when people leave treatment and go back into those same environments. And in fact, there's a wonderful study that a colleague, Alicia Reed, conducted. And this study, again, is also available in the Social Science and Medicine issue on structural stigma. And what Alicia did is she reanalyzed data from a meta-analysis of individual level HIV prevention interventions with African Americans. And these studies had been conducted all throughout the United States in a variety of different communities. And what she was able to do is to get a measure of the level of prejudice against African Americans in those different communities by linking a data set from the ANES that had a measure of racial attitudes. And so she had a variety, so obviously across the US were these different communities where there was a lot of variation in the levels of prejudice. And what she showed is that these individual level HIV prevention interventions among African Americans were very strongly effective in communities with low levels of prejudice. But in communities with very high levels of prejudice, the effect size for these individual level interventions was essentially null. And so I think we need to think more carefully about our interventions, and when they're rolled out in very different social contexts, this provides some information about why we often see very poor effect sizes for our individual level interventions. That they may in the short term be effective, but over time we see the effect size be less and less effective. So I think we need to start thinking about these social environments and structural forms of stigma as modifiers of intervention effectiveness. So that has implications for the kinds of interventions that we do in different environments and different communities that differ with respect to the level of stigma that's in those environments. One researcher asked about how could qualitative research methods contribute to understanding how structural stigma works. And I'll say a couple things about that because I think it's a really good point. One comment is that, as I've mentioned, in a quantitative way, for quantitative designs, we have to have enough variation in structural stigma to be able to detect an effect. And for some forms of structural discrimination, it's called what Jeffrey Rose called a ubiquitous exposure, meaning there's no variation. So we can think of the Defense of Marriage Act in the United States before that was overturned as a ubiquitous exposure because it was a federal law that applied to all 50 states. In terms of whether or not how marriage was defined across all 50 states. So we might have thought that that was an important risk factor for health among LGBT populations, but we couldn't examine it quantitatively for a while because, again, it was invariant across the 50 states. There's no variation. So I think qualitative designs become very important when we have these ubiquitous exposures because quantitatively we're somewhat limited with what we can do. And I think qualitative information there in those instances can become crucially important to really getting some traction on how these structural forms of stigma may be affecting individuals. The other is that I think these kinds of mixed methods research projects are crucial. And so I'll say one example that for some colleagues and I have been working on the impact of anti-bullying laws and policies on bullying among LGBT populations in schools. And so quantitatively, we're able to look at do rates of bullying change before and after these policies are implemented. But we don't know, if we find an effect, we don't know why that effect has occurred. What is it about these policies that change institutional practices within the school context that may explain why we're seeing these beneficial effects of bullying? And there, we're working with ethnographers and qualitative researchers who are going to go into the schools and really conduct these kind of qualitative interviews to really get a sense of what's happening on the ground in terms of how these policies are affecting what happens. So again, I think qualitative research can play a very important role here. And we have time for one more question. One other one that I guess is somewhat similar to what I've said, but what suggestions you have for public health professionals to better address these disparities. I think it's a both and here. It's clearly continuing to do interventions at the individual level because these structural changes are protracted and they occur over time, and there are clearly many people suffering as we wait for these structural forms of stigma to be reduced. And so I think individual level treatments, mental health treatments, and other treatments are very important. At the same time, I think public health professionals should also be turning their attention to these broader structural conditions and changing the kinds of institutional policies and practices and social norms that in many ways are generating a lot of the stigma and discrimination against these different stigmatized groups. So I'll just end here by saying the next presentation will be by my colleague Dr. Bates, who's here in the Department of Epidemiology, and she's going to be talking about immigration and health disparities beyond acculturation. So definitely stay tuned for that. So thank you very much for your time, and I appreciate the opportunity to get to talk about our research. Thanks.